Have you ever really thought about the powerhouse organs working tirelessly 24/7 just to keep your entire body in balance? Well, you've come to the right place. Today, we're taking an amazing anatomical journey deep into the kidney, starting from its place in your body and zooming all the way down to the microscopic marvels that make it all happen. So, let's get started.
All right, here's our roadmap for the day. We'll kick things off with the kidney's real job as a master regulator. Then we'll pinpoint exactly where they are. After that, we'll peel back their protective armor, take a look inside, and then zoom way in on the microscopic nephron before, finally, mapping out the incredible vascular highway that fuels this whole operation.
So let's start with the big picture, the kidney's main role. And I've got to tell you, it's so much more than just a simple waste disposal system. Its real job is way more complex. And honestly, it's absolutely vital to keeping your entire body in perfect harmony.
Now, the urinary system itself is a masterpiece of design. You've got two kidneys doing all the heavy lifting, two ureters acting as transport tubes, one bladder for storage, and a single urethra for removal. It's simple, it's elegant, and it's just incredibly effective.
But see, getting rid of waste, that's just scratching the surface. The kidneys are the true masters of homeostasis, constantly fine-tuning your blood. They regulate everything, from its ionic composition and pH levels to your overall blood volume and pressure. They even manage the body's water balance and produce crucial hormones like calcitriol and erythropoietin. Seriously, they're doing so much more than we ever give them credit for.
Okay, so where exactly are these retroperitoneal powerhouses located? Let's go ahead and pinpoint them in the body. Visually, they're pretty much what you'd expect, a pair of reddish bean-shaped organs, and each one is about the size of a standard bar of soap. They sit just above your waist. And here's a classic anatomical fun fact for you. The right kidney is always just a little bit lower than the left one. Why? Because the massive liver on that side literally pushes it down. If we want to get really precise, they're nestled right on the back wall of your abdomen, somewhere between the T12 and L3 vertebrae. And this location is important because it means they get some partial protection from your 11th and 12th ribs, your floating ribs. For a physical therapist, this is something you absolutely have to remember, because a fracture to those ribs could potentially damage a kidney. This location brings us to our key term of the day, retroperitoneal. It sounds fancy, but it literally just means behind the peritoneum. The peritoneum is this thin, slippery lining inside your abdominal cavity, and unlike your stomach or intestines, the kidneys are tucked safely behind it. This gives them fantastic protection and stability.
Okay, now that we know where they are, let's see what keeps them safe. I want you to think of it like the kidney's own personal suit of armor, and it's made up of three very distinct layers of defense.
So if we work our way from the inside out, the kidney is wrapped in three different layers. Right up against the organ itself is the thin, fibrous capsule. It's what holds its shape. Then you've got a thick cushion of perirenal fat that acts like a shock absorber. And finally, the whole package is anchored securely to your body wall by the tough renal fascia.
Now that we've seen the outside, let's go even deeper. If we were to just slice a kidney right open, we'd immediately see two very different internal regions. There's an outer cortex and an inner medulla.
And the contrast between the two is pretty striking. The outer renal cortex is a lighter red color with a smooth texture. But the inner renal medulla is much darker, and it's where you find all the cone-shaped structures that do the real work.
Yeah, inside that dark medulla, we find the renal pyramids, these really prominent cone-shaped masses of tissue. The narrow tip of each pyramid, which we call the renal papilla, points inward, toward the center. And separating all of these pyramids are the renal columns, which are actually just extensions of that outer cortical tissue diving down into the medulla.
What this all creates is this perfect little drainage funnel. So fluid leaves the very tips of the pyramids and collects first in these little cups called the minor calyces. Then those merge into larger major calyces, and they all pour into one single large basin, the renal pelvis, right before exiting down the ureter. It's a brilliant system.
All right, this brings us to the most detailed part of our journey. We are now zooming way past what the naked eye can see and diving into the microscopic world of the nephron. This is the true functional unit of the kidney.
Okay, get ready for a pretty mind-boggling number. Each one of your kidneys is packed with about 1 million of these tiny little filtration factories. That's right, 1 million per kidney. It's these nephrons that are actually performing all that complex regulation we were just talking about.
So what exactly is this little microscopic workhorse? Well, the nephron's job is to filter your blood and produce urine. And you can break it down into two main parts. You've got the renal corpuscle, which is the filtering unit, and then you have the renal tubule, which is this long tube where all that filtered fluid gets processed.
Now this is really cool. It turns out not all nephrons are created equal. The vast majority, something like 80 to 85%, are what we call cortical nephrons, and they have these short loops. But then there's this crucial minority, the juxtamedullary nephrons. They have these incredibly long loops that dip way down deep into the medulla, and it's these long loops that give the kidney its remarkable ability to concentrate urine.
Finally, let's talk about the fuel for this whole operation. None of this filtration could ever happen without an absolutely enormous blood supply. So let's trace the path of the renal vascular highway. I promise, it's one of the most impressive circulatory routes in the entire body.
Think about this for a second. Your kidneys make up less than 0.5% of your total body weight, yet at any given moment, they're receiving a staggering 20 to 25% of all the blood your heart pumps. That is a huge amount of blood constantly flowing through these tiny organs, which just goes to show you how critical their work really is. The path that blood takes to get to each nephron is kind of like a continuously branching tree. It all starts with a massive renal artery, which then splits again and again into segmental, then interlobar, then arcuate, and cortical radiate arteries. Each branch just gets smaller and smaller until it finally ends in a tiny little afferent arteriole that delivers blood right to the glomerulus, that little ball of capillaries where filtration begins.
And the journey out is just as intricate. This part is unique. Blood leaves the glomerulus and immediately enters a second set of capillaries that wrap all around the tubules. This is where all the crucial exchange happens. From there, the veins start to merge, basically reversing the arterial path, from cortical radiate to arcuate to interlobar, until all that processed blood collects in the main renal vein to exit the kidney. It's just a brilliant design for maximum efficiency.
And there you have it, a complete anatomical journey, from the kidney's place in the body right down to its microscopic blood supply. We've mapped out the entire structure, but how does the filtering actually happen? Well, you'll have to join us for our next explainer, where we're going to dive right into that renal corpuscle to witness the magic of blood filtration up close.
Today, we are diving into one of the most amazing feats of engineering happening inside your body right now, the kidney's incredible filtration engine. We're about to see how these organs pull off a job so massive, it's almost unbelievable.
So take a look at this number, 180 liters. That is roughly how much blood plasma a guy's kidneys will filter in a single day. For women, it's still a mind-blowing 150 liters. And we're not just talking about your total blood volume here. We're talking about the fluid part, the plasma, getting cleaned and processed again and again and again.
To really put that into perspective, 180 liters is over 47 gallons. Think about a huge trash can or a small bathtub filled to the brim. Your body pushes that much fluid through a microscopic filter every single day without you even having to think about it. The sheer scale of this is exactly what makes it so fascinating to understand. So how on earth does the body pull this off? Well, here's our game plan. First, we'll get the big picture of how urine gets made to see where filtration fits in. Then we're going to zoom way in and build the amazing filter itself, layer by layer. After that, we'll get into the physics, the pressure game that drives this whole thing. And then we'll see the smart controls the kidney uses to keep the rate steady. And finally, what happens next? Okay, let's start with that big picture. You see, that massive 180-liter filtration job, it's really just the very first step in a super coordinated 3-part mission to keep our blood perfectly balanced. So this mission has 3 stages. Step 1 is glomerular filtration, and that's our whole focus today. This is where the kidney just dumps a huge amount of water and small stuff out of the blood. But then comes step 2, tubular reabsorption, where the body, being super smart, reclaims about 99% of all the useful things it just pushed out. And finally, step 3 is tubular secretion. This is like the last call for trash, actively kicking out any leftover waste into what will eventually become urine. It's this brilliant system of just filter everything first and ask questions later.
All right, let's zoom in on step 1. This all goes down inside a tiny structure called the renal corpuscle. And at its heart is the filtration membrane, an incredibly sophisticated 3-layer sieve. Let's actually build it together, from the inside out.
So the very first layer the blood hits is the wall of the capillary itself. But these are no ordinary cells. They are absolutely riddled with big pores, called fenestrations, which makes them super leaky. Think of this as the first coarse filter, kind of like a pasta strainer. It lets all the water and small solutes just pour right through, but it's tight enough to hold back the big stuff, our red and white blood cells and platelets.
Now the second layer, the basement membrane, this is where things get really clever. This isn't just a physical barrier, it's an electrical one. It's a mesh of collagen, sure, but it's also studded with molecules that have a negative charge. And since most of the big proteins in our blood also have a negative charge, they get physically repelled, just like trying to push 2 magnets together the wrong way. It's an awesome trick to keep our valuable proteins in the blood.
And the final layer of our super sieve is made of these really cool-looking cells called podocytes. They have these long foot-like arms that wrap all the way around the capillary, and the tiny gaps between these feet create the final checkpoint, the filtration slits. This is the ultimate gatekeeper, making sure only water and the tiniest solutes like glucose, ions, and waste like urea can get through. Okay, so we've built our high-tech filter, but what's actually pushing 180 liters of fluid through it every day? Well, the answer comes down to physics and a constant battle of pressures. Let's get into it. The key idea here is something called net filtration pressure, or NFP. And really, it's just the final score in a tug of war. It's the main force pushing fluid out of the blood, minus the 2 forces that are trying to pull or push it right back in. So on the pushing out team, we have the undisputed champion, glomerular blood hydrostatic pressure, or GBHP. This is basically just the blood pressure inside these special capillaries. And it's unusually high here, around 55 millimeters of mercury. This pressure is the main engine driving everything through the filter. But it's not unopposed. Fighting back, we have the capsular hydrostatic pressure. You can think of this as back pressure. It's the force from the fluid that's already been filtered and is now sitting on the other side of the membrane, kind of pushing back with about 15 millimeters of mercury. The second opposing force is a little different. It's the blood colloid osmotic pressure. This isn't a push, it's a chemical pull. Remember all those big proteins that got left behind in the blood? Well, they act like little sponges, trying to draw water back in through osmosis. and that pull is pretty strong, about 30 millimeters of mercury.
So let's do the final calculation. We've got our big push of 55 going out, and pushing back, we have 15 from the back pressure and 30 from that osmotic pull. So 55 minus 45 gives us just 10 millimeters of mercury. Isn't that wild? This entire massive filtration process is driven by this tiny, delicate net pressure. It's a system of powerful forces held in a perfect, fine balance. Now, holding on to that delicate 10 millimeter Hg balance is absolutely critical. So what happens when your blood pressure goes up and down during the day, like when you exercise? How does the kidney stop the whole system from going haywire? Well, it has its own brilliant local smart control system. The thing we need to keep constant is called the glomerular filtration rate, or GFR. It's just how much filtrate is made every minute. We want to keep this in a Goldilocks zone, not too high, not too low. If it's too high, stuff flies through so fast we can't reabsorb what we need. Too low, and we don't clear out waste effectively. So keeping GFR stable is everything. So let's ask the question, what happens if your blood pressure suddenly spikes? Logically, that would ramp up the main pushing force, and your GFR would go through the roof. But nope, your kidneys have their own little brain, called renal autoregulation, that stops this from happening. The first line of defense is called the myogenic mechanism. It's so simple, it's genius. When a spike in blood pressure starts to stretch the smooth muscle in the artery leading into the filter, that muscle just automatically flexes in response. It squeezes down, narrows the pipe, and instantly reduces the blood flow, bringing GFR right back to normal. It's a pure physical reflex, and it's super fast. The second system is a bit more high-tech. It's a feedback loop. Here's how it works. If GFR is too high, fluid zips through the tubules too fast for them to grab enough salt. Special sensor cells down the line, called the macula densa, notice this extra salty fluid. They then send a chemical signal back to the entrance that basically says, hey, slow it down. They do this by cutting off the release of nitric oxide, which is a chemical that keeps the artery open. No nitric oxide, the artery tightens, blood flow goes down, and GFR gets back to normal. It's a really elegant feedback system. So what's the big takeaway here? Why does any of this matter? Well, it's because your kidney health and your blood pressure are locked in this constant dance. Chronically high blood pressure literally hammers these delicate filters, damaging them over time. And on the flip side, if your kidneys aren't working right, they can't manage your body's fluid levels, which causes fluid to build up and, you guessed it, raises your blood pressure. It creates this really dangerous, vicious cycle where each problem makes the other one worse. And that wraps up the incredible first step of this whole process. The blood has been successfully filtered, and what we're left with is basically protein-free plasma, ready for the next part of its journey. But the story is far from over. Now the body has to go on a huge recovery mission to reclaim all the good stuff it just dumped out. And that is exactly what we will explore in our next explainer. You know, your kidneys are these amazing filtration machines, but honestly, that's only half the story. The real magic, the real genius, happens right after the initial filtering. Inside millions of tiny little tubes called nephrons, there's this incredibly elegant system that reclaims everything your body needs and makes sure to kick out what it doesn't. So let's dive in and follow this journey to see how your body pulls off this great reclamation. Okay, so first up, we're going to look at the sheer scale of this reclamation mission. Then we'll follow the path through the main workhorse, the PCT, before getting into the very clever loop of Henle and the fine-tuning that happens at the end. We'll wrap things up with secretion, which is basically the kidney's specialized system for taking out the trash. I want you to think of kidney filtration like casting a huge, messy net into the ocean. It pulls up almost everything small, the treasure and the trash. And, well, that creates a huge problem, right? How does your body get all the good stuff back before it's lost forever? 99%. Just let that sink in for a second. That's the staggering amount of water your kidneys filter that absolutely must be reclaimed and returned to your blood. If this system ever failed, you'd be in serious trouble in just a matter of minutes. I mean, to put that into perspective, 180 liters is around 45 gallons. We're talking about the size of a small oil drum. Your body filters that much fluid every single day. Without a system to get the good stuff back, you lose your entire plasma volume almost instantly. So yeah, reclamation isn't just important. It's a constant life or death mission. So the solution to this whole mess? It's called tubular reabsorption. That's the official name for this rescue mission where the cells lining the kidney tubules grab all the useful stuff from the filtered fluid and return it to the blood where it belongs. Okay, so substances basically have two ways to get back into the blood. The first route is paracellular, which is kind of like sneaking through a leaky fence. The fluid and solutes just move between the tubule cells. The other path, the more controlled one, is transcellular. Here, a substance has to pass directly through a cell, almost like going through security, crossing two different membranes to get back to the bloodstream. All right, so where does all this action take place? Well, the very first stop is the proximal convoluted tubule, or just the PCT. If the nephron is a reclamation factory, the PCT is the main assembly line. It does pretty much all of the heavy lifting. And wow, it is an absolute powerhouse. The PCT reabsorbs about 2/3 of all the water, sodium, and potassium almost immediately. But its most critical job, reclaiming 100% of vital nutrients like glucose and amino acids. Your body literally can't afford to lose even one of those molecules, and the PCT makes sure it doesn't. So, you're probably wondering, how on earth does it manage to grab every single bit of glucose? Well, it uses this brilliant trick, First, the cell uses a ton of energy to pump sodium out of the cell. This creates a powerful vacuum-like pull for sodium to rush back in. Then, a special protein on the other side acts like a bouncer at a club door. It'll only let sodium back in if, and only if, it brings a glucose molecule along with it. The glucose basically gets a free ride into the cell, and the whole thing is powered by sodium's desperate desire to get back inside. It's so clever.
Okay, so once the PCT has done all that heavy lifting, the leftover fluid enters the loop of Henle. Now, this part of the nephron isn't really about bulk reabsorption. Nope, it has a much more specialized and, frankly, much more clever job to create the perfect environment to concentrate urine later on. The first part of the loop, the descending limb, is like a net made only for water. It's super permeable to water, but it blocks pretty much all solutes. And as this tube dives deep into the super salty inner part of the kidney, the medulla, water is just irresistibly pulled out by osmosis. This means the fluid left inside gets saltier and way more concentrated the deeper it goes. But then, here comes the plot twist. On the way back up, the ascending limb is the complete opposite. This part is totally waterproof, no water can get through it, but its walls are just packed with powerful pumps that are actively throwing sodium, potassium, and chloride ions out into the surrounding tissue. This is what makes the medulla so salty in the first place. And all that pumping leaves the filtrate inside very, very dilute, even more dilute than blood.
You know, this whole incredible system with fluid flowing down one side, up the other, and with completely different rules for each limb, well, it has a name. Countercurrent multiplication. It is just an incredibly efficient design that uses this opposing flow to build and maintain a massive salt gradient. And that gradient is the secret weapon that lets the body control our water balance so precisely down the line. All right, this brings us to the final stretch, the distal convoluted tubule and the collecting duct. You can think of this as the quality control section of the factory. This is where the body makes tiny, hormonally controlled adjustments to meet its exact needs at that very moment. You've got two main types of cells doing the work here. First are the principal cells. They're in charge of salt and water balance, reabsorbing sodium and getting rid of potassium, all under the command of hormones like ADH and aldosterone. And right next to them, you have the intercalated cells. These guys are the body's pH managers, meticulously handling our acid-base balance by reabsorbing bicarbonate and secreting hydrogen ions. Okay, so up until now, we've been all about saving the good stuff, right? But the nephron also has to actively take out the trash. And this is where tubular secretion comes in, and believe me, it has some major clinical importance. And that brings up a pretty logical question, doesn't it? If the filtration process is so powerful, why do we even need a separate system for getting rid of waste? Why not just filter everything out in the first place? Well, the answer is pretty simple. The filter isn't perfect. A lot of substances, including common drugs like penicillin and other waste products, travel through our blood by latching onto really large proteins. They're just too big to squeeze through that initial filter, so filtration alone just can't touch them. And that's where secretion comes in. It's the fix. It's an active transport system that literally pulls these substances out of the blood and the capillaries surrounding the tubule and pumps them directly into the filtrate. It's the kidney's way of making sure that what can't be filtered out still gets thrown out with the garbage. And this is where it gets really, really interesting from a clinical standpoint. This whole process can actually be manipulated. See, a lot of drugs are either weak acids or weak bases. By changing the urine's pH, doctors can literally trap a drug in the filtrate, which forces the body to excrete it way faster. This is an absolutely crucial tool when treating things like drug overdoses. So when you put it all together, you can see it's a perfect partnership. Reabsorption moves the essentials from the tubule back to the blood, like saving every last drop of glucose. Secretion does the exact opposite, moving waste from the blood into the tubule, like making sure to get rid of penicillin. They're really just two sides of the same coin, both working around the clock to keep everything in balance. And that, right there, is the incredible end result. These two processes work together in perfect harmony, taking that initial massive 180 liters of brute force filtrate and masterfully refining it down to just 1 or 2 liters of urine, a final product that is perfectly, exquisitely tailored to maintain the delicate balance of your entire internal world. But believe it or not, the nephron story doesn't even end there. It's not just a passive filter, it's an active communicator. In our next explainer, we're going to look at how the kidney acts as a powerful hormone-producing organ and explore its critical and often volatile relationship with your blood pressure, some kind of biological cleaning system for our blood. And, that's totally true, but it's barely scratching the surface. Today, we're going to go way beyond the filter to uncover the kidney's secret life as a powerful command center, an organ that's issuing critical orders to your entire body. So here's our game plan. We'll start by pulling back the curtain on the kidney as a secret hormone-producing gland. Then we'll see how it actually helps make blood, how it activates an essential vitamin, and how it runs the master control system for your blood pressure. And finally, we're going to look at a tragic feedback loop and see what happens when it all starts to go wrong. Let's dive in. All right, so to really get what the kidney is all about, we have to kind of reboot our thinking. It's not just a passive filter waiting for things to come to it. No, it's an active, dynamic endocrine gland that's sending out its own powerful chemical messages. And this slide just lays it out perfectly. On the left, there's the job we all know about, filtering out the junk, super important. But on the right, that's where the magic happens. We see its hidden, and you could argue much more powerful, role, making hormones that travel all over the body, giving orders to everything from your bones to your blood vessels. Okay, so let's check out our first big example of this command and control function, making blood. And yeah, you heard me right. The journey to creating brand new red blood cells, it actually gets its start right here, in the kidney. See, the kidney is like the body's ultimate oxygen sensor. As your blood is flowing through it, moment by moment, specialized cells are checking the oxygen levels. If they sense a dip, a condition we call tissue hypoxia, they immediately sound the alarm. And that alarm is a hormone called erythropoietin, or EPO for short. Think of EPO as an urgent dispatch sent from kidney command straight to the red blood cell factories located in your bone marrow. And the message is simple. Hey, we're low on oxygen carriers down here. Ramp up production now. And this chart just drives home how unbelievably important the kidney is in all this. A staggering 90% of all EPO is made right there. Yeah, the liver helps out a little bit, but the kidney is, without a doubt, the main player. This is exactly why people with kidney failure almost always get severe anemia. Their main signal for red blood cell production has been shut off. But the kidney's job as a commander doesn't stop with blood. Next up, we're going to see how it's absolutely critical for building strong bones, all by activating vitamin D. And that's a non-negotiable step for controlling the calcium in your body. So the most important word here is active. The kidney produces something called calcitriol, and that's the only form of vitamin D your body can actually use. Without it, you could drink all the milk in the world, eat all the cheese you want, but your intestines just can't absorb the calcium. Calcitriol is literally the key that unlocks the door. You can think of this whole process as a multi-organ relay race. You get the inactive vitamin D from sunlight or food, the liver gets the baton first, does a quick conversion, but it's the kidney that runs that final critical anchor leg of the race. It performs the last chemical tweak that turns that vitamin into useful, active calcitriol. Without that final step from the kidney, the whole process just fizzles out. All right, now for the main event. If the kidney is a command center, then the renin-angiotensin-aldosterone system, or RAS for short, is its most powerful weapon. This is the master system it uses to manage your blood pressure, day in and day out. Let's walk through this chemical chain reaction. It all kicks off when the kidney senses a drop in blood pressure or blood volume, maybe from dehydration or an injury. In response, it releases an enzyme called renin. Renin floats around until it finds a protein made by the liver, angiotensinogen, and it converts it into angiotensin 1. Then, as that blood passes through the lungs, another enzyme, ACE, gets a hold of it and does one more conversion, creating the real powerhouse of the system, angiotensin 2. And let me tell you, angiotensin 2 is no joke. It is one of the most powerful blood vessel constrictors the body can make. It works almost instantly, squeezing the tiny muscles in your artery walls all over your body. This sudden narrowing of the pipes immediately cranks up your systemic blood pressure. It's the body's emergency override switch for a pressure drop. But angiotensin 2 is a multitasker. It doesn't stop there. It also acts as a hormone, traveling to the adrenal glands, right on top of the kidneys, and tells them to release another hormone, aldosterone. Aldosterone's job is to circle right back to the kidneys and tell them to hang on to more sodium. And as we know, where sodium goes, water follows. This expands your total blood volume, giving you a much more long-term fix for that low blood pressure. Okay, let's just hit pause and recap the key players here. You've got renin from the kidney, which kicks the whole thing off. Then you have angiotensin 2, the heavy hitter, causing that intense vasoconstriction. And finally, aldosterone, which acts as the long-term volume manager, telling the kidneys to hold on to salt and water. It's a truly brilliant system designed to keep us alive. But here's the tragic twist. What happens when this amazing, life-saving system turns on itself? Well, in the case of chronic high blood pressure or hypertension, this brilliant solution becomes a destructive, self-fueling problem. It all starts with physical damage. I want you to imagine taking a high-pressure fire hose and aiming it at a delicate silk screen. That is basically what chronic high blood pressure does to the microscopic blood vessels and filters, the glomeruli, inside your kidneys. Over time, this constant pounding causes scarring and thickening. And this is where a truly vicious cycle kicks off. First, that damage from high pressure actually reduces blood flow inside the kidney itself. Now, the kidney is a smart sensor, but it has a massive blind spot. It can't tell the difference between low flow locally and low blood pressure everywhere else. So it thinks the entire body's pressure is crashing. And what does it do? Exactly what it's designed to do. It hammers the RAAS system to fix the problem. But of course, this just makes everything worse, driving your body's blood pressure even higher, which causes more kidney damage, which makes the kidney activate RAS even harder. It's a devastating feedback loop that just speeds up the organ's own destruction. Eventually, these very systems, now twisted into a destructive cycle, just can't keep up anymore. The damage becomes too much, and the kidney starts to reach the end of the line. And the consequences are just profound. This quote really says it all. When these systems fail, or when the nephrons, those little filtering units, are just overwhelmed by toxins and a lack of oxygen, the entire system collapses. Not just the kidney, but everything it controls. So, that leaves us with one huge, critical question. We've seen how the kidney is this powerful commander, regulating our blood, our bones, our blood pressure. So what happens when that master regulator finally fails? Well, join us next time, because we're going to explore the catastrophic body-wide
Today, we're doing a
effects of
deep
both
dive
acute
into kidney
and
failure.
chronic kidney failure.
Our kidneys are these incredible, sophisticated filters that work around the clock, but when they shut down, the whole system starts to crash.
So that's really the big question, isn't it? What actually happens when these master filters go offline? This isn't just about one organ failing. It's a chain reaction, a cascade of events that ripples through your entire body, affecting everything from your brain all the way down to your bones. So let's get into it.
You know, kidney failure isn't just one thing. It actually takes two very different paths. On one side, you've got acute kidney injury, or AKI. Think of this as a sudden dramatic crash that, believe it or not, can often be reversed. But then on the other side, you have chronic kidney disease, or CKD. This one is a slow, silent, and permanent decline, and telling these two apart is absolutely crucial.
To really unpack all this, we're going to walk through 5 key sections. We'll kick things off with the basics of what it means when the filters fail. Then we'll look at the sudden breakdown of AKI, contrast that with the slow burn of CKD, and then see what happens when it all leads to a system-wide crisis. And we'll wrap it up with a big picture takeaway.
All right, let's start with Section 1, when filters fail. Before we get into the nitty-gritty of the different types, let's just be clear about what we're talking about. What does it actually mean when we say the kidneys are failing? Well, in a nutshell, it means they've lost their two main superpowers, clearing out waste products and keeping the body's fluid and electrolyte levels in perfect balance.
Okay, so let's jump right into our first major scenario, this sudden, almost catastrophic failure that we call acute kidney injury, or AKI. You can almost think of this as the emergency room version of kidney failure. It's fast and it's serious.
So technically speaking, AKI is this abrupt drop in kidney function, and it can happen over just a few hours or a couple of days. The immediate consequence is something called azotemia, which is just a fancy way of saying there's a buildup of nitrogenous waste, like urea in the blood. But here's the most important part. AKI is potentially reversible. If you can figure out what's causing it and fix it fast, the kidneys can often bounce back.
So what could cause such a sudden breakdown? Well, it really comes down to 3 main pathways. A great way to think about it is like a plumbing system. Prerenal means the problem is before the kidney. Not enough blood is getting to the filter in the first place. Intrarenal means the damage is inside the kidney itself. The filter is actually broken. And postrenal means there's a blockage after the kidney, so urine can't get out.
And here's what that looks like in the real world. Prerenal AKI, that can be set off by something like a major hemorrhage or heart failure, basically anything that causes a sudden drop in blood pressure. Intrarenal AKI is direct damage, often from nephrotoxic drugs or a prolonged lack of oxygen, which can cause something called acute tubular necrosis. And postrenal AKI is a straightforward physical blockage. Think kidney stones in both ureters or an enlarged prostate clamping down on the urethra.
Now, a case of AKI usually plays out in 4 distinct phases. It starts with the onset, which is the initial injury or event. That's followed by the oliguric phase, where urine output just plummets and all those waste products start to pile up. Then things start to turn around in the diuretic phase. The kidneys are healing and they start making a ton of urine, but they're not great at concentrating it yet. And finally, you have the recovery phase, where kidney function slowly but surely gets back to normal.
Okay, now let's make a hard pivot. We're going from the sudden shock of AKI to the slow, sneaky decline of chronic kidney disease. And trust me, this is a whole different ballgame. CKD is all about the GFR, the glomerular filtration rate. It's defined as a GFR of less than 60 for 3 months or longer. And here's the key difference from AKI. This decline is both permanent and progressive. It doesn't get better. And the main culprits driving this slow motion destruction are usually long-term conditions we all know about, like diabetes and high blood pressure.
Now here's what makes CKD so incredibly deceptive. The tiny filtering units in the kidneys, the nephrons, well, they can't regenerate. Once one is gone, it is gone for good. So to pick up the slack, the remaining healthy nephrons get bigger, they hypertrophy, and they work overtime. And this incredible ability to compensate is exactly why CKD is known as a silent disease for years, sometimes even decades.
And this is the truly mind-blowing part. Because of that amazing compensation, a person can lose up to 80%, 80, of their total kidney function before any significant symptoms start to show up. It's like the body is hiding a catastrophic failure right up until the very end.
The progression of CKD is actually mapped out pretty clearly across 5 stages, and it's all based on that GFR number. In stage 1, there's some kidney damage, but the GFR is still pretty normal. By the time you get to stage 3, function is moderately down. And stage 5, with a GFR below 15, that's it. That's end-stage renal failure. And at that point, you're looking at dialysis or a transplant to survive.
So that brings us to the end of the line, the final outcome of unchecked kidney failure, whether it got there fast with AKI or slowly with CKD. This is the point where the loss of function sets off a full-body, system-wide crisis called uremia.
Uremia literally means urine in the blood, and it's as bad as it sounds. It's the clinical syndrome you see when the kidneys just can't do their job anymore. It's not one single symptom. It's this avalanche of problems that hits pretty much every single organ system in the body.
First up, let's just look at what happens when filtration fails. The body can't get rid of water and salt, so you get fluid overload and swelling everywhere. That's edema. It can't get rid of potassium, so you get hyperkalemia, which can trigger deadly heart rhythm problems. And it can't manage acid levels, so the whole body chemistry goes haywire with metabolic acidosis. Then you've got the toxic buildup of all that waste. This hits the nervous system hard, causing something called uremic encephalopathy. We're talking confusion, fatigue, even seizures. It also damages the nerves in your hands and feet, causing neuropathy. And the GI system gets hit too, leading to constant nausea, vomiting, and a total loss of appetite.
And finally, we can't forget that the kidneys are also hormone factories. When they fail, they stop making a hormone called erythropoietin, or EPO, which you need to make red blood cells, so you end up with severe anemia. They also stop activating vitamin D, which is critical for absorbing calcium. This throws your mineral balance completely out of whack and leads to a painful, complex bone disease called renal osteodystrophy.
So after seeing this complete system meltdown, what's the really crucial takeaway here, especially for those of you who work in healthcare?
It really all boils down to this. The kidneys are so much more than simple filters. Their job depends on incredibly complex anatomy, the delicate physics of filtration, and their role as a hormone producer that reaches the entire body. When you truly grasp all that, you can really appreciate just how critical they are and just how devastating it is when they fail.
And that leads us right to our final question, something for you to think about. Now that you've seen the sudden crash of AKI, the silent creep of CKD, and the total body crisis of uremia, how is this deeper understanding going to change the way you observe, assess, and care for your clients from now on?